Welcome to the Health Systems CIO Show. I'm your host, founder, and editor-in-chief, Anthony Guerra. On today's episode, I'll be speaking with Sriraman, CTO at Mass General Brigham. Sri, thanks for joining me today.
Thanks for having me, Anthony. Good afternoon.
All right, great. Do you want to start off by telling me a little bit about your organization and your role?
Mass General Brigham is one of the largest academic medical centers in US and one of the largest academic research center in healthcare. We are about $23 billion company. Our predominant catchment area, our patients area is around Eastern Massachusetts. And my role in Mass General Brigham is a Chief Technology Officer. I'm responsible for all of our digital technology strategy, architecture, strategic partnerships, and technology governance or digital governance.
Excellent. Very good. All right. So today we're going to have a really fun chat about sort of vendor trust and reliability and sort of a business continuity type thing. You wrote, why don't we start out? You wrote and posted sort of an open letter to the SaaS providers, saying, hey, here's where I think there may be some shortcomings. Here's where we want you guys to step up. Here, it's all about patient safety, and there's some issues that you have identified that give you concern. So it was sort of an open letter, I think you called it. So do you want to start off by telling us a little bit about the genesis of that? Obviously, it's something you were thinking about, feeling for a while. You decided to put it in words and put it out there in that fashion. Just tell us a little background on that.
Yeah, sure. I think this happened about last summer, probably late summer, early fall last year, when we saw a series of outages in the public cloud space where most of the health systems were not directly impacted, but some of the SaaS providers that we leverage were impacted. And we did not, when I say we, not just Mass General Brigham, we had a very limited outage, but just looking at my peer organizations and talking to many of my colleagues, CTO colleagues in other organizations, we all felt that we had no transparency on where the SaaS providers are actually deployed, right? It's cloud providers, hyperscalers or private hosting. And also, it also was triggered by the back of the true premises of deploying in multiple regions, right? For disaster recovery purposes, we know that one region may go down, one area may go down, we deploy in another region, so completely isolate, so that when one region fails, we know we have a second region to fall back into. We also notice that some cloud hyperscalers, they run the control plane jointly. So when one region goes down, it has taken the other region down. Those services are interlinked.
Wow.
So that was the premises of having had to send that note to our partners and say, hey, at the least you need to divide the control plane so that one region doesn't impact another region.
All right, very good. When we say SaaS providers, are we talking about the big names we think of in healthcare, the EMR vendors, the Workdays, like all the major applications? That's what we mean, correct?
So they are, and also healthcare is predominantly a bot organization, meaning we buy a lot of software. There's a lot of smaller players also offer. Most of them used to be shrink wrapped, which we used to deploy in our data center. They are also moving to deploy in their own environment or on hyperscalers.
Okay, very good. So we know that from a sort of a big picture point of view over a longer period of time, um, everyone had everything on premise, and then things started to move to the cloud. I don't know if there's been a little bit coming back where people say, yeah, maybe not everything in the cloud. Maybe there's some things that need to be on premise. What are your thoughts there? Are you a everything in the cloud guy, or do you think there are some workloads that belong on premise? Obviously, maybe there's been an evolution in your thinking, and maybe you sort of were very pro cloud, but now you see some sort of reliability issues that we're talking about today that give you a little pause and say, let's pull a few things back. It used to be a few years ago, 10 years ago, it was great. Everybody wanted to say, get rid of your data centers. No data centers. No data centers in healthcare, right? Everybody in healthcare, it was if you were running a data center, you were a dinosaur. What's the current thinking?
Yeah, so maybe I'll just go back a little bit, also opportunity to how my thinking has evolved over a period of time. Way back, I did the first cloud strategy for Thomson Reuters way back in 2008. But at that time, we had, Thomson Reuters had 6 data centers, regional data centers all around the world. 2 pair per region. Americas 2 data centers, Europe 2, and then Asia 2. And given that real-time critical nature, at that time when we looked at it, cloud, and it is also now we're talking about almost 15 years ago, right? AWS has launched pretty decently at that time. Microsoft is just catching up, very, very early days and catching up with them. When we looked at it at that time, it was we had a highly mature data center operations and with our own buildings, everything invested in. So from that point of view, economics didn't work at that time. And fast forward over the last 10, 15 years, economics have actually significantly improved, right? The cloud economics have significantly improved. On the other hand, as you said, most of the organizations running the data centers become dinosaurs, right? Over a period of
Yeah.
time. So obviously there is a significant leverage and benefit in migrating stuff from on-prem to the cloud. Coming to MGB and our current thinking, we are on-prem. We are in 2 data centers today. Our long-term strategy is to migrate pretty much as much we can into the cloud because the cost is coming to a situation where the you know if you level up the capex and then on all the opex you spend on-prem, when you add up that it actually cheaper to run on cloud, right? That's and a high mathematics we are at this point. Even to run electronic health record, either we run it on a hyperscaler or run it on a third party hosting centers like Epic Hosting, etc. I think the economics are there. At the same time, all of a sudden now AI is coming, a lot of research related workloads, needs heavy workloads, GPU workloads. We still don't have a cloud economics to run proportionately. So, as you look forward in the next few years, majority, at least my personal view, the heavy GPU workloads requiring for language model tuning or even deep learning, like in academic research, like what we have, they are always going to require some form of um, local hosting, whether we use it our own data center or leverage some other colos, etc. And then majority of commodity workloads will go to the cloud. That's my personal take.
Yeah, it's a question for you. Very, very interesting. Um, are you thinking that AI and the way AI is working, and that metered sense you get of the meter running, like it being an old time cab, the old cabs when you're driving around the meter, you're watching the meter go up.
Yeah.
Um, I don't know. It feels like this could get really scary from a financial point of view if the LLMs and sort of the meter running, because it's very addictive in a good sense. The usage, it's very addictive. We're in this weird time where we want everyone to jump headfirst into AI usage for personal productivity. We want that because we want people to be more productive. But the LLM providers, they're not stupid. And it's almost like get you hooked. Once you're hooked, they can increase the prices a little bit at a time. You boil the frog. The frog never knows that it's boiling. All of a sudden it's boiling. I'm just feeling like we're getting to get in real deep with these LLM providers on this meter, with the meter running. You have thoughts about that? And is that some trend?
Absolutely.
Go
I
ahead.
I'll give my personal example, right? So personally, I'm subscribed to OpenAI and Anthropic, right?
Yeah.
And when we signed up with Cloud a few weeks ago, um, it was supposed to be for my son, grown-up son, who was 26 years old. He wanted to use it. I'm like, okay, Dad, let's use Dad's credit card. So we bought an annual subscription for $200. Done. Okay. Then 15 minutes later, my credit card has been sending me text messages every 5 minutes. Hey, I charged another $10, another $15. I'm looking at what's going on. The default setting in Cloud is because you are allowed to use X number of tokens within a short time. And then once you exceed it, it automatically charges. That is your default setting. So we found out in 10 minutes later, we turned off that. And then all of a sudden, now I'm not automatically charged. It's asking you permission to charge at least, right? So imagine we cannot do that on an enterprise level, right?
No.
So that's where we are very, very, cost conscious, especially healthcare, not-for-profit organizations like ourselves. We are extremely cost conscious. So that's where, we when it comes to productivity, employee productivity, we allow quite a bit of, we give them quite a bit of co-pilot like tools, offices by Copilot, ambient documentation. They're, and that is all corporate mandated, negotiated, enterprise price, cost that we negotiated and offered to our employees. On the other hand, many of the AI use cases, we are looking at real ROI, right? Based on the ROI, if there, like any other digital capability, if not, just because AI is available doesn't mean that we want to leverage and burn money, right? We want to use it and it has to deliver value.
Yeah, it's just we're in an absolutely fascinating time right now, and we're right in the middle of this, and it's got to be managed because, as you said, I think we're all developing these personal stories of the cost of AI. It felt at first like, oh, was just going to be a free ride. And all of a sudden it's like, like you said, you have one subscription level, you hit the wall on that, you go to the next one, you hit the wall on that, and you're doing it, you're using it, you're being productive, but all of a sudden you're spending money. So,
Yeah.
it's just very interesting.
I think that's a dynamics, right? Each of us needs to balance it. It's like, okay, I spend a lot of time with OpenAI. It definitely helps me, the amount of time as a CTO doing research, right? Research time is compressed on an average daily 1 to 2 hours is compressed down. Okay, now I can use the time to do
Right.
more work or do more, where I can add value, right? So my thinking time is getting better and better, right? So that's perfectly okay when you're personal productivity, but it doesn't translate like that for departmental productivity kind of a work, right? When
Hmm.
you start deploying agentic AI, we are not there yet. And agentic AI, especially in healthcare, we are in a very, very nascent stage.
Right. Yeah, so to your point, excellent point. Just because something costs money doesn't mean it's not worth what you're spending. That's a different question. It may
Yeah,
be very
exactly.
much worth it, but as you said, you have to make sure there's an ROI when you're doing it at an enterprise level. And agentic is very interesting. At the super early stages of that, right?
Yeah.
Really, I mean, sort of, I think it's kind of interesting. So the ambient listening technologies seem to have totally worked out well, right? I mean, that's just, but there's not forgive me, there's not a tremendous amount of sophistication in that when we compare it to sort of sophisticated, complicated agentic workflows where you don't have to do anything and things that took 3 or 4 people now are just hands off. That's a long way down the road, it seems like. Ambient listening is basically a fancy like recording and transcribing, right? It works and it works beautifully and it's helping people. I'm not disputing that, but those are two different worlds that we're talking about.
Yeah, absolutely right. And even the agentic, it's the ambient documentation, it took almost 3 years to be now prevailing, capability for every doctor, in the ecosystem, right? If you remember, if you go back in 3 years ago, the first versions of ambient documentation, they were hallucinating very badly.
Oh yeah.
My own personal experience, it didn't pick up my accent, right? It had quite a bit of, misquotes in that. Then we have to go back and fix it. But then, my last visit to my doctor doesn't have to do anything. So things have significantly improved in the last 3 years. But the beauty of that technology is so simple. You press
Right.
the record button, you stop it, things get uploaded automatically, get into your electronic health record. I think, it needs to be that simple, for adoption also for us.
Yeah, and the problem, right? The challenge is when you're doing that kind of ambient listening we just talked about, it is capturing the data at that point and then working with that data, which is
Yeah.
totally different than some technology that's accessing a whole boatload of data created over the last 30 years, some very poorly, and then trying to get intelligence based off of that. Two very different things.
I think this is where we are in an era of kind of confusing ourselves with, you know, predictive reasoning versus deterministic reasoning, right? When I look at agentic AI, if it has to be, if the action is not able to be deterministic, we have a problem. It cannot be probabilistic,
But that's
right?
what it is, right?
Right? So
Yeah,
agentic AI right now, it's all about probabilistic.
right.
But until the probabilistic becomes deterministic, right, it's going to be very hard for ourselves to convince that you can actually let the AI agent execute autonomously, right? So
Right.
I think that's where I still am a big fan of machine learning algorithms. It's predictive algorithm that we continue to fine tune, and we know that we can very clearly explain that if you run this algorithm 10 times, the answer is going to be the same, not 10
Yeah,
different ways with the generative model with generative AI.
right. I say it's not a calculator. So don't think you're
Exactly.
going to get the same answer. I was using it this morning and it's doing things. I'm like, "What are you doing?" It's like a junior employee who sometimes doesn't pay attention, right?
Oh, I
And
have to
I'm
yell
like,
at my OpenAI many
"Yeah,
times to say, what, didn't you not say see my instruction from 3 steps ago?
exactly." I'm like, why are you doing that? You know you're not supposed to do that." And it's like, "Oh yeah, you're right." So it's amusing. But all right, let's go back to our issue with the SaaS providers. So I'm thinking of it in two buckets here to be practical for people like yourself and other organizations. You have arrangements that you are in, contracts that are signed. Um, Perhaps you want greater visibility into the kind of dynamics that you're talking about. There would be certain things you could do in that scenario. And then you would have possibly new contracts, new partners you're looking to take on. Maybe you're switching off of old ones. And you probably have a little more leverage to request information and documentation and see things. So if you want to take those one at a time, what would your advice be to people on, with these concerns in mind about reliability and uptime, what would your advice be for kind of at least addressing as best you can those two buckets?
Yeah, I think, in both the scenarios, at least based on our experience, the partners are willing to share, right? It's about us framing the question and asking them, okay, hey, our criticality of your software running in our environment, and then you laid out and you have a conversation. It's just that we all assumed it, right? For the last 15 years, this is how we ran on-prem. That's how when you go to the cloud, okay, there is a region dependent independence, right? If you deploy in one region, it's not going to work, impact. But over a period of time, things have commingled together, and nobody start continue to ask those questions anymore. So now again, we have to go back to the drawing board and say, okay, do the paper-based exercise. When I deploy in one region, what happens to my other region? When I fail over, how long it takes to fail over? Who is the point to trigger? What decisions as a customer we have to make? What decisions the vendor has to make? I think we forgot to ask all those questions that used to ask many years ago. So I think it's bringing back the discipline of resiliency back into the conversation.
Hmm.
When we have the conversation, our partners are great. They are happy to share that. It's not that they are willingly hiding or anything. It's just that we have forgot to ask the questions.
So you think in general, at least for the major SaaS providers, the major vendors health systems are using, you would suspect that they are doing the things that you expect them to be doing?
Yeah, most part, right? There are probably few elements of interconnect. That is what showed us that there is a crack in those interconnects that they inadvertently designed it. So they have to go back and fix that. Apart from that, it actually works, right? If we look at it, typically on-prem deployment, you are now deploying 100% on both sides, significantly sunking your cost for DR, right? Which is sitting idle. And then when something happens, you have the control to switch over, but is the sunk cost worth it, right? You're asking the question. On the other hand, in the cloud, I can spin off the DR, which is in a dormant state, to almost close enough to and bring it up without that sunk cost. So I think there are pros and cons. I mean, nobody's doing anything deliberately to harm customers, right? It's just that sometimes uh, the the crosswire interconnects the regions for whatever reason, and they need to go back and unwind once they figure out that, okay, oops, we made some mistakes here in the design.
Right, right. Um, so I would imagine for folks in your position, it might be a good exercise to make a list of things that you would like to know about your vendors from the resiliency point of view, and just say to yourself, do I know these things? Do I know the
Exactly.
answers? If I don't know I'm not comfortable not knowing these things. So I'm going to develop sort of a questionnaire and I'm going to send it to all my major vendors so I have some peace of mind. And there, I'm going to do it that way rather than I don't ever want to be asked by my board, hey, did you know this? And go, no, I didn't know. I didn't know they didn't have this in place. You don't
Yeah.
want to be in that position, right?
Yeah, absolutely, right? Just going back one of the examples, we lost one of our SaaS connectivity during that period. Uh, it was if it not happened during October 31st, it would have been fine because that's our benefit closing day, right? And that day, the benefit last day of the deadline of the benefits closing, that site went down. What we didn't know was that benefits are hosted on one of the hyperscalers that went down. So the site didn't go down, the hyperscaler went down for a prolonged period that day, right? So the lessons from that is, hoops, we never asked them where are they hosting, which region they are hosting. So when we first got the outage node, oh, if that hyperscaler went down, we also, oh, that means that we would have been more proactive to say, okay, these SaaS providers hosted on the hyperscaler are also got impacted. So what's our fallback? Right. So again, not knowing that information was a hindrance, especially on that particular day on October 31st.
Yeah, very good. It makes me think of that Log4j situation where people
Yeah,
didn't know if they had it or not. So
exactly.
that was sort of an inventory thing. This is another sort of vulnerability map I'm picturing in my head. And
Yeah,
you need to, if some, let's say, like you said, a hyperscaler goes down. Well, do any of our vendors use that hyperscaler in that region rather than trying to figure out at that point to have that knowledge, to have that map is what you want, correct?
exactly. Right. Having so at least it gives us a little more planning time to say, okay, I deal with that incident. So in this case, until the employees start complaining, we didn't know that that benefit site was down. Right. So, but we know that the hyperscaler went down few hours before.
Yeah, you always want to be in a position of if your boss asks you, does this affect us, to be able to say yes or no,
Exactly.
right? You know, we're good,
We know that it's already we're taken care of, or
Right.
we know it is impacted. We know how to fix it or how to tackle it, right? So you don't want to be in the situation when the boss says, and then you respond, "Oh, I have no idea. Thank you very much, boss."
Oh, that's great stuff. Okay, let me ask you this. Let's talk about scenarios. So it's very interesting when we talk about disaster recovery, business continuity planning, and insurance and things like that. Um, People have different expectations. They envision different scenarios that they want to uh, be able to deal with, right? Some may be concerned, may say, listen, I want to make sure, my area of my state, like that's where I'm picturing the biggest, to use a poor term, blast radius. Like if
Yeah,
something happens within 60 miles of my hospital, I want to make sure we can recover. Somebody else may say 500 miles, right? Somebody may say the United States. Like I want to be able to fail over to something in California in case there's an incident that takes out half the country. We all have different scenarios we want to plan for, and the larger your scenario, the more money it costs usually. So what's a way to think about that? Insurance is important, but you could buy way more insurance than you ever needed to cover the tiny risk that almost will never happen, but if it did, it'd be catastrophic. But nobody can navigate life that way. So, what are your thoughts?
yeah, no, that's a great question, which we grapple, very frequently. Probably I would split the question into two parts, right? One scenario is not cyber related, the other one cyber
Yeah,
related,
right.
because that kind of gives us a way to, um, decompose the risk to be more manageable. And then if you look at the non-cyber related disaster scenarios, um, the worst case scenario is we lost connectivity to our data center if you are an on-prem, right? So WAN, a digger it went through the cables on
Right.
both ends of the data center, right? If we have a dual lines, God forbid, some digger ran through, we lost the connectivity, or we lost the connectivity from the providers. That can also happen, right? Both the
Hmm.
providers got hit for whatever reason they got stuck. So I think our first reaction to any of these major calamities that we lost connectivity to our core services, then what we have done is, I've seen this in other organizations too. you kind of tier your criticality of applications that you run. So right, the most critical, mission critical, some people call crown jewels in Europe, right? So you don't, so let's say on a typical enterprise, you run anywhere between 1,000 to 2,000, 3,000 applications that runs in a day. The question is, do we need all 1,000, 2,000 are critical on that particular day when you are in a disaster scenario, right? So we kind of have this mental map of tier 0, tier 1, tier 2, tier 3, tier 4, tier 5. So like 6 layers, at least in our environment. The tier 0 being the core infrastructure, pretty much all the things that needs to get the basic plan before even I restore the first application. And then we have a set of applications based on the priority. Of course, for us, electronic health record up and running is the highest priority, right? Epic is our electronic health record. So that is part of our tier 1 application. And there's a bunch of applications like lab work, blood bank, just, etc., some radiology. So many of those applications are classified in the tier 1. So when there's a disaster happen, we start looking at this. Okay, if these applications are down, that's what our triaging is. It's like classic. You go to emergency room, the doctor looks at you, how sick are you? Based on the sickness with other patients, okay, you just
Right.
got a little cut in your leg, go sit in a corner. I'm going to take care of somebody who's got a heart condition who's come in an ambulance. So in this case, so very similar idea. So we triage and create a list of applications that will start restoring it, right? Once the conditions are met, once we are able to recover or even invoke the DR. So I think best practices. I'm sure most of the organization will start thinking about it, or if not, they already have it. I think if not, I suggest start from there. Tearing your critical application, because when you have 2,000 applications running, like when CrowdStrike happened, everything is down. All 2,000 applications are down. So where do you start? Right? There are certain things you can wait for even 10 days or a week. It's not going to impact. So what is that you need really at that moment to get your business going, and then work downward to the lower priority applications?
Yeah, that's going to be a very interesting exercise. And these things are probably always far more complicated than they seem when we discuss them, because
Absolutely.
you
And
probably can't. Go
also,
ahead.
the sometimes it's not just an application. You want to look at end-to-end business process that tie
Mm,
to the whole ecosystem. For example, maybe 10 applications may be participating in that one process. So you may want to bring that as a first wave of applications, because
right.
just bringing one application doesn't mean, it doesn't actually solve the problem. It is still in a hung state because you have a dependent application that needs to come up. So I think, this is where the scenario planning, frequent tabletop exercise is all important.
Yeah, that's an excellent point. That idea, the interconnectivity and waves of applications and workflows, and looking at it that way. So you've got that's a complicating factor to doing this, and then we could look at sort of volume of use, and you look at the EHR. You say, well, everyone uses the EHR, so of course it's up there. But then I suppose you would also have other applications that are more nichey, but are extremely important, to those users, and to things like surgery and whatnot and things like that. So you much have much lower volume of users, but a high level of criticality. So I'm picturing a very complicated project or process of working this out with a lot of coordination and discussions with the operations and the clinicians, because you don't want to be deciding in IT what's critical. You want them to be deciding, but
Yeah.
everybody's going to think everything they use is the most critical. So it's tricky.
So this is what, part of our emergency preparedness. All hospitals have their own emergency preparedness outside of digital and IT. We work with them very closely and define the process. And this is their classification in terms of tier 1, tier 2, tier 3, in what order to recover, right? It is a joint planning that we have done, and we continue to refine that. But what CrowdStrike taught us was, okay, you can't just be at application layer, you also need to worry about infrastructure layer. So that's where we added tier 0, that even before I touch my first application, is my WAN connectivity is up and running, is my wireless access up and running, is my DNS working? So all of those things we check the box before even look at, okay, where's my first application to restore?
Yeah. So here's a question for you. So I did a story. I think it was at HIMSS. I went to HIMSS, and there was a great session um, on isolated recovery environments, uh, and it's been number one on our site for weeks. So I think there's a huge, your piece was about resiliency and business continuity. This piece is essentially about business continuity. I think there's a massive appetite for that content because I think health systems are very tuned in. And there were other stories I've done recently at the shows. There were a lot of sessions on running beyond tabletops, actually live disaster recovery drills in business. There's a massive focus on this. Does that resonate with you? Obviously, I think so.
Yeah, absolutely. So we do periodic tabletop exercise,
Mhm.
especially on key critical applications and scenarios. So, for example, electronic health record Epic, right? So we look at Epic disaster recovery. We do a paper-based exercise on tabletop exercise, and we also alternate running our data center every 6 months because when we upgrade one, the next version, what we do is we flip the data center. So we know that 6 months is running out of one data center, another 6 months is running out of data center. We know that both of them are in a good state without having to worry about, okay, when we flip, is it even going to come up? And we also run periodic DR tests for our environment. So I think the isolated recovery environment is a concept. As a concept, it's really important, right? The question about isolated recovery is, it's in the name, right? What do you want to absolutely recover first when
Yeah.
you are like everything is down scenario? That's what the tiering is kind of helping us, right? So I think it's a really important that people think about, when you are in a completely lights out mode like CrowdStrike or future crowd, any cyber related issue, ransomware scenario when everything has been break, take a moment and hopefully you had a plan of, okay, this is where I'm going to start and start working through the list when you are ready to start recovering.
Yeah, it's a really good point. It relates to this tiering of applications. And, as you mentioned, the isolated recovery environment, it's sort of, they described it as like a lifeboat. You're not going to live in it, but it's a temporary, it's a smaller environment. It's not a complete mirroring. It's not a backup environment. It's just a small temporary survival situation. So that's very important. And again, one of my biggest things that I talk about and like to cover is how important it is for IT executives at health systems to have deep, continuous, meaningful relationships with the operations, the clinicians, um, because you can't. What we're talking about, what you're trying to do, you can't do it unless you deeply understand operations and their priorities. Correct?
Oh, absolutely, right. It's other, it absolutely spot on, right? We cannot operate. So that's where, as I said, as previously alluded, we have an emergency preparedness team that takes care of the operational readiness, downtime procedures, and also business continuity plan, right? At a macro level, we dock into that process very seamlessly. So even today, when there is even a small IT incident happen, there's always our emergency preparedness team representative joining the call, and they make an assessment to say whether it is a major incident or a medium incident or a minor incident. We don't make that assessment. They make the assessment based on the facts that we present, and then they will invoke the right protocol to address that incident during the incident process.
So how have as sort of you're sort of a pure technologist, right? You're not a healthcare guy per se.
I'm
Uh,
not a doctor.
you're not a doctor. So you have had to learn a lot about the healthcare environment. Um, and tell me about that. Tell me about that process of working with clinicians, what that's been like from having previously not worked with clinicians. How might they be different than some of your previous internal customers you were supporting?
Yeah, I mean, if you look at my career, I've been probably four different major sectors I've been on. Professional information, Thomson Reuters, CPG, consumer goods in Unilever, pharma, Novartis, and now healthcare. Each one, the first 6 months I spent literally walking the floor, learning things, meeting people. My great experience coming into Mass General Brigham was 4 weeks into my role. I had a tour of our emergency rooms and operation theaters. And one of them was literally the surgery is just completed. They are still cleaning as we walked into the OR. having that experience, spending time following a clinician, following a nurse practice in the floor, and also just walking, talking to folks we have about 15 hospitals. So I did pretty much all this hospital touring. So we do some structural sessions, and also I also just ad hocly go up and show it to a meeting, department and say, hey, I want to just follow what you guys do. So I
Right.
did that in one of our hospitals with the radiology team. As the patients are coming in, I was able to see literally ER emergency patients and also elective patients coming for CT scan, watching them do the CT scan, reading their, radio, right, looking at the radiology report images and them dictating into the dictaphone, into the, solution, into the writing the reports, etc. That's how you learn, right?
Yeah.
And then trying to compare to, okay, yeah, how does this compare to, the marketing team in CPG industry versus a supply chain or a manufacturer or a manufacturing team or a logistics team. So trying to compare and contrast with the role other stakeholder community I worked with, and you build, continue to build. I think that technology is such a leveler, right? All sectors uses technology. Technology is not is a differentiator, right? However, it's the nuance of applying the technology to a particular stakeholder community. And one thing I used to joke in my past life, at least the software doesn't kill people. Here it can kill people, right? So
Oh
that's why
boy.
very, very important that we make sure that human impact is not underestimated.
Does I mean, I can't imagine what it's like for you, like when you walk around one of the hospitals and you walk around the town, the city, and you look up at the hospital and you're like, I help support the technology for all the people getting care in there. That has got to feel different than professional services, as meaningful as that may have been. I mean, it's got to be pretty special what you're doing right now.
Yeah, to be honest, sometimes, there are places where we have recently upgraded our wireless access points, as simple as a wireless access
Yeah.
points, right? And when people, when patients, family comes in, now they're able to access their phone seamlessly through a wireless access to check whatever they are checking, right? Even that simplest capability, deploying that, seeing that, having, and now we have a decent Wi-Fi in the lobby, as example, that gives you goosebumps when I look
Yeah.
back and think about it. Yeah.
It's pretty cool. Pretty cool stuff. All right, my final question for you, then I'm going to let you go. Um, give your best pieces of advice to someone in your position, so a CTO at another health system. Let's say they're a little younger than you, starting out more at the beginning of their career, and you just want to give them your best piece of advice on how they can be successful.
Yeah. I think, most of the health systems actually, all struggle with financial, ability to invest, right? It's a known fact. I think, if somebody taking on a CTO role or a CIO role, the first thing I would suggest they look at is how's the foundation, right? How's the network capabilities? How much technology debt has been incurred over a period of time? Rightly, it's not about being right or wrong. It's about understanding the technical debt that you are inheriting, so that you have an educated, guessing in terms of where you want to invest in the future. So do take time to assess, how much technology debt is incurred in the organization, and then plan your next 90 days, 180 days, first year plan. Because otherwise, what happens is it could be overwhelming when you come in. Oh my God, what did I get into, and where do I start? Right? So at least it helps you compartmentalize and say, yes, there's a lot of issue, a lot of underinvestment over the last 10 plus years. COVID didn't help. So now where do I start? I think it will help with that once you understand the technical debt coming into an organization.
And it sounds like, just as a follow-up, it sounds like think about foundation, network, infrastructure before you're worried about that higher level kind of stuff.
Absolutely. There is always somebody who's keeping an eye on the shiny stuff in the front end, right? There are other people but as a CTO, CIO, or a VP of technology operations, whatever the title is, right? Your job is to make sure that the entire hospital runs on a silent mode, right? Silent operations. You don't want to see incidents happening at your network connectivity or servers going down to make sure. So make sure that the plumbing is right before we pay attention to the shiny objects, because there are a lot of people looking at the shiny objects.
That's right, Sri. Listen, that's about all we had time for today, Sri. This has been delightful. And I hope I can reach out to you down the road and we can reconnect.
No, absolutely. Thanks for having me, Anthony. And I really enjoyed the session and looking forward in the future.
Very
Thanks.
good. Have a great day.
You too.